as a Pacific Health Information Network Secretariat, and I promise, to open this webinar tonight. We are recording this. Bit of not convenient time for a lot of our colleagues in other countries. So we wish, that we can, share the presentation later. So our topic tonight is the use of biometrics for health. WHO has conducted a study how the biometrics could be used for the health service management and what would be the feasibility to do it in the Pacific. And as part of this work, our consultant, Dr. Lee Kironget, who is making the presentation tonight, he has conducted a study on this, and based on his vast experience managing the biometrics in the health sector, he will give this presentation for us tonight. Over to you, Lee.
Hi, thank you very much, Katri. I hope I'm very clear. I hope everyone can hear me. And thank you all for joining. My name is Lee. I've been in biometrics for quite a while now, and I'm very happy to do this. So just to quickly start on this, when Katri and I and the rest of the team sat down and decided to do a lot of in-depth study on biometrics in health, and specifically in the region, one of the things that we decided to, we came up with was the main challenges, in biometrics and in the region. So first of all, the things we saw was, according to the World Bank, there's already 1.1 billion people without a legal identity. That basically means they're completely invisible to the world. That's 1.1 billion. And that is 1 in 2 women in low-income countries. The second big challenge that we saw was, we already, as a global community, we've committed to leaving no one behind. But we've committed also to reduce poverty, to improve health outcomes, but we don't have the ability to know if we're hitting those targets or not, because we don't know who we're dealing with, who we're serving, and whether they're receiving the services that we have promised to give it to them. If we go a little bit back and now to look at the health sector and what are the big challenges that are there, I was looking at when we did our research in the Pacific. So first of all, found that there's a lack of accurate health records. This includes vaccine records. We've also realized that ideally, because of a lack of identity, the idea of digital health is already out, because people we're not registering people, we don't know who they are. Then there's very limited verified data, and we're going to see this later, verified data and verified service. So if, for example, if a frontline health worker tells us they've vaccinated 10 people, how do we know really they've vaccinated 10 people? Based on my experience working out with frontline health workers in several countries, we realize sometimes not everyone is as honest as we want them to be. And also, because of that, we end up really losing, for example, I'll give an example of in Ethiopia, we're running a program there where we send out frontline health work, community health workers, and they'll go out to the field and tell us they've vaccinated 30 people. So when we introduced biometrics, we realized they were scanning their own fingerprint 30 times. So when we did the deduplication, we were seeing they were not really vaccinating people. They were just sitting under a tree. So these are the key challenges that we identified. So what do we do about this? Specifically the Pacific, and this one, let me speak a bit on what we experienced in the Pacific. First of all, there's really no formal universal identity across the different countries that we've seen. And the result is, therefore, people don't have an health ID. So people use patient ID cards and sometimes have barcodes. So the problem with this is several. People lose these cards. So it's not always that someone has their cards when they show up to a medical facility. Physical cards also, now in terms of during Ebola, now during COVID, what we've realized is physical identity can be a source of transmission. The second thing we noticed is also names. If any of you have been in many countries like I've been, you'll see people use the same name. Could be Abdullah, it could be names are really not unique enough as an identifier. And second thing, names are always being misspelled, depending on who's spelling. Data entry errors are quite common. People put in the wrong age. There's so many other things that can go in that are not data entry errors are commonplace. And therefore, what we found out, without a unique identifier, people, a frontline health worker waste a lot of time trying to identify who you are, trying to register who you are, trying to pick up patient records. And therefore, what we've seen is actually lives are lost when people sometimes receive the wrong vaccine or receive a vaccine twice, or they cannot get their medical records in time. So according to the World Bank, the past presidents say biometrics and digital identity is really a game changer when it comes to pandemics, when it comes to health, when you're trying to identify and give people services. So let's take a little bit of time right now and see what really is biometrics. So in the Pacific, we did take a bit of time. It's not a really new thing. So biometrics has been used now more and more. People use biometrics to open up their phone. People use biometrics to board planes, to get services. So this is just a snapshot of what is happening in the Pacific. So that biometrics use is not something completely new. It's being used for public TB screening. It's used for NCD management in Kiribati. And also right now, Kiribati is in the process of engaging a biometric company to actually roll out, I think it's the University of Sydney, to roll out biometrics for NCDs, I think. Also, sorry, someone's mic is on. Excuse me, just mute your mic, please. Thank you. All right. So it's not completely new, the idea of biometrics in health in the region, but also we realize that because of this absolutely very little unique identifiers in the health sector, and part of our study figured out now biometrics can be the game changer and should be the game changer in the region now. So let's just quickly jump in and see what is biometrics really. So biometrics comes from a compound word, bio and metric, which basically means a measurement of life. It's an automated way for recognizing people based on their physiological or behavioral characters. So I like using this example. What do we know? If you want to log into your computer, you use your password. That's what we know, and that can easily change. Who are we? Our legal identity, that's like a passport. What we are is biometrics, really, because you cannot change biometrics. So the physiological parts of biometrics is the ones that we normally use is fingerprint, as we all know, iris, which is now a scanning of the iris, face, we take a picture of the face and do what's called facial recognition. More recently, there's palm and vein print. I want to speak a bit on the last three. Because of what COVID has done, we've moved away, we're trying to move away from what is called contact biometrics into contactless biometrics. So instead of taking your fingerprint and then having to clean or the burden of ensuring that the devices are clean is left on the frontline health worker. And we've seen that this has really, COVID has really impacted most of the work we were doing in the field. And therefore, there's now a concerted move within the space to move from contact biometrics to contactless. So there's a lot of advances that have been done now on facial recognition, palm print and vein. The idea being maintaining the recommended WHO social distancing and yet being able to register or confirm that an individual is who they claim to be. The other thing you'll hear a lot now is what is called behavioral biometrics. And this is mostly used when it comes to in the aid industry. It's mostly used when you're trying to give cash assistance and social payments. So for example, I'll give you in Somalia, what we're doing now there with the World Bank is sending people social assistance because of the flooding and all that's happening. But to confirm who they are, because it's remote, we use a voice print. So they just pick up their phone and confirm that it's them. And using voice print, we're able to quickly decide who they are. So this is just an overview of what biometrics really is. So how does it work really in the health sector? Basically, you use biometrics in two ways. It's called enrollment and identification. Enrollment is now when someone walks in, the triage nurse would probably do one thing. You want to know who this person is. So you enroll their biometrics. You take either their picture or their fingerprint or their palm print, and then put it into the system. From there forth, now an individual has a unique identity. The second way we use biometrics in health is in the identification. A patient walks in, they put their fingerprints or their biometrics, and you identify who they are. That is called one to N, right? And one of the things we've done, especially now again, I want to really emphasize some of the work we've been doing is been accentuated by COVID-19. So when COVID-19 hit, we did a lot of studies, and what we realized is testing, tracing, and surveillance is really critical in ensuring that we flatten the curve, so as to speak. So to make sure you accurately identify individuals so that you can actually follow up with them. During the course of the past few months, most of the countries in the Pacific have written to me individually and asked me, so we want to run biometrics. What does it look like? Instead of going into the details of what technology it should be, I decided to show just an overview of what biometric solutions should look like. And maybe I should take a pause here and just to explain. Biometrics now, as we are approaching it, is a technology and not a legal identity. A legal identity, biometrics can help with legal identity, but biometrics in itself does not give you an ID. It gives you a unique identifier in what we call a functional in a functional space, like in health, in voter registration, in births and deaths, but it's not a legal identity, which is a human right. So what biometrics should look like? First of all, this is very critical. Technology must be robust. It should be designed specifically for very low resource settings, offline work, and to make sure it can work in dusty places. I've seen amazing shiny technology that cannot work in the field. So the technology must be robust. The second quite important thing that most people forget and don't do it is to make sure that whatever biometric solution you're coming up with has been pre-integrated with most of the digital platforms we have, that is DHIS2, Comcare, OpenSRP, and all the rest. So that really helps because biometrics on its own is really useless unless you integrate it with other digital platforms, especially in electronic health. Third mistake that I've seen many countries and many individuals do is going and recruiting or hiring a biometric firm that is not using open standards. What do I mean by open standards? Open standards is like the SI standards that have been approved. This makes sure there's no vendor lock-in. So what really happens with most vendors now, they come with their own proprietary software and they make sure it's not based on the ISO standards. And therefore, once you sign them on, your data is completely encrypted. It's completely unique to their platform. And therefore, it makes sure in future, you cannot use that data, although it's your own data, you cannot use it with a third-party provider. You cannot connect it to, let's say, plug it into a voter registry or plug it into the CRVS. So this is quite important to make sure you use open standards. And I cannot overstress enough privacy by design. And I'll talk a bit more on this. There is now, I don't know if, so one of the countries that has decided to do massive biometric registration for health was two countries I really want to talk about too, India and Kenya. So India now has the largest biometric database, and one of the biggest challenges they had from the courts was on privacy. Kenya also made a massive rollout last year, and they spent, I think, $11 billion trying to register biometrics for people to ensure that they can receive health services and towards what they call universal health care. Just a few weeks ago, the Supreme Court ruled that all that exercise was illegal because privacy was not at the center of it. So $11 billion has gone down the drain because the architects of the scheme did not consider privacy first and data protection. All right, so let's take a bit of time and just we want to look at a few use cases and see where biometrics has been used and how it's helped. So we're really going to look at three. You remember the first areas we looked at, that is verified service, vaccine coverage. And now let's see, for example, a case of Nigeria. In Nigeria, only about 22% of the children are fully vaccinated. That compares to, if you compare the vaccine coverage, the gap between the Ministry of Health's data versus the WHO estimates, it's almost 34%. That in itself is shocking. Gavi did a separate study in 2019 in Chad. And in Chad, now the known difference between coverage rates as per the administrative data compared to the survey data, it's almost 50% points. That basically means about 700,000 vaccines were unaccounted for. In Rwanda, another example, Gavi also did an audit in 2019, and they found gaps up to 42% between stock levels and the administrative data. So basically what I'm saying, when it comes to vaccine, studies have shown that what we get from the MIS data from the Ministry of Health versus what the survey data is giving us, it shows us sometimes up to 75% discrepancy. So that basically means we're wasting a lot of vaccines. We don't know if these vaccines are reaching who they're supposed to be reaching. And this has become a problem. So the second thing I want also to visit, and this is very unique. This was orchestrated by actually COVID. And I want to see how we can use biometrics also in vaccine value chain. So this is a very rudimentary, a very oversimplified physical flow of vaccine delivery. As you see, it's being manufactured. And let me just walk everyone through this. See, the manufacturing is here. It comes to the national storage. And here we see the big problem here is we don't know whether the vaccines are understocked or overstocked. So once it gets in country, we get the WHO, the UNICEF, and the NGOs to do the deliveries and distribution. And you see here also the big challenge is keeping the vaccines cold. So it gets to the regional facility. We also here, we don't know if they have enough vaccines or not. These are common problems. Again, these are very oversimplified flow. Sorry. And you see here also at the clinic, we don't know what patients, we don't have patients record, and therefore we have inaccurate health records and missing patient. And the result of this is there is no information flowing up into the national electronic health system. So with biometrics, what happens? You see, immediately when we introduce biometrics, you still, of course, have the problem of stocks here, and the problem of the cold, keeping the vaccines cold. But you see now, at the clinic level, with biometrics, we're able now to have accurate health systems. You see with biometrics, the data that we are collecting can now feed up into the national health system. And therefore, from the national level, you are able to see exactly who you're vaccinating or how your vaccine program is going. But more importantly, at the village level, at the clinic level, there's accurate data. And now people can get their second shot, whether it's COVID or whatever vaccine you're doing. But now at the clinic level and the village level, we have accurate data. And that's thanks to biometrics and other digital platforms. Lastly, what I really found very interesting in and I mentioned this earlier, in most of the programs we've done, we found out that sometimes not all frontline health workers are as honest as we want them to be. In Ethiopia, we found out that most of them would go sit under a tree for the whole day, throw the vaccines out and say, oh, I already vaccinated 50 people today.
Okay.
So with biometrics, we are able to make sure that if they say they've vaccinated someone, it's verified. And therefore, we make sure we know that the service we are trying to offer is actually the service they're providing. Secondly, on this, with biometrics in Ethiopia also, we were, as you can see in this diagram here, you can have geotagged biometrics so that when a frontline health worker says they're in this region, we know exactly where they are. And also it gives us near real-time data. So you can actually try and plan properly and say, okay, this region now is experiencing enough footprint. And
I would very much understand her explosive emotion at the moment and her way of responding. Yeah.
That's
a huge stress response right there. That's acting out emotions.
Could you please mute?
What happened? Or we already went over it.
Is there a way we can mute whoever is speaking? Oh, thank you. Perfect. So basically, what does that mean? With verified service and verified accurate data, it basically means now that every single vaccine, every service, every dollar reaches the people who we want them to reach. And again, I've seen this a lot in the field. For example, I want also to point out, again, and I'm going to use Ethiopia again, because that was quite a unique case for me, where not only the frontline health workers were not doing what they were supposed to do, but they were throwing vaccines away. They just sat under a tree and threw the vaccines away. So a lot of money was saved when we introduced biometrics. Now, just specifically, so one of the things people ask me, so Lee, this is all good, biometrics is good. What should we think about when we want to deploy biometrics? And again, this is a massive, massive overview, but these are very critical points. First, before you deploy biometrics, think, is there a legal basis for collecting, sharing, processing, and storing of your biometric data? Now, here is where most people really fail, because if you don't make sure that the country you're operating in has the legal framework to collect the information and to store it. Another big thing here is now, where do you store the information? Most countries are very strict on sharing, on storing personal identifiable information on the cloud. They want to make sure that that data is stored within the boundaries of the country. Other countries have said that is okay. So I've seen biometrics projects fail because people want to store it in the cloud. which is cheaper, but the laws and the regulation in the country do not allow that. Now, second, and also very overlooked thing is, what biometrics are you collecting and how is it acceptable in the local community? A few years ago, I was in Papua New Guinea and I made a mistake of, I was out in the field and I made a mistake of pointing someone with my finger. I was almost burnt at the stake there in one of the little villages because that was found to be very offensive. It was found to be against everything that their cultural norms believed in. In Liberia during the Ebola crisis, again, I was out in the field trying to sensitize the population on what Ebola is and how Ebola operates. And there I was almost again burnt for being a witch because the number we were trying to use for correcting the information on Ebola was 4666, and they say that's the devil's number. So what I'm trying to emphasize here, when you comes to biometrics, make sure you understand what you're collecting and how the community perceives it. If the community does not allow, in a few villages in Kenya, for example, and in rural Tanzania, taking pictures is considered stealing the soul of a child. So you have to make sure you sensitize the community. And this is where it's really important to do a proper stakeholder analysis and an influence matrix and see who in the community can influence attitudes and perceptions. So it could be religious leaders, it could be a teacher, whoever is trusted in the community is someone you should be working with. And again, extremely important. If you don't get the community behind you, then whatever shiny technology you have, whatever goals you really want to achieve will fail. So when we did the study across not only the Pacific, but also across similar economies, we started looking at what are the benefits that we've seen that biometrics brings in the health space. First was increased accuracy. It was very easy for someone to walk in and say, look, this is me, definitely, therefore it could not be anyone. Biometrics is almost immutable. So we found out that it made it very, very easy for frontline health workers to identify and pull out health records. Second thing that we found that was very interesting was the reduction of fraud, and I want to reduction of fraud in so many cases. I'll speak to specific cases in Uganda where we found, or when we deployed biometrics there, we found out there was, I think, 700,000 fake refugees in the camp there. And therefore was quite an embarrassment to the government and to UNHCR at that time. But one of the things we found about biometrics really cuts fraud in terms of ensuring there are no, first of all, there are no ghost workers, whether it's in health or in education or in refugee management, it reduces fraud. Second, what I realized, which is quite, the third is efficiency and continuity of service. And I'm going to just a bit of, when we talk about increased accuracy, just want to point out ADA, which is the Indian system, which is now the largest biometric database. According to studies, just introducing biometrics, it's going to save $11 billion a year through government expenditure. So that is, second thing, efficiency. And this was very important. I just wanted to point out this. And continuity of service. So, and this is a big problem also in the Pacific, where data is not shared and cannot be shared from one facility to another. But with biometrics giving you a unique identifier, that means you can link that data to any other data system that you have using biometrics as a unique identifier. Enhanced privacy, and this we did 2 years ago, I did a study with the University of Maryland in Malawi. And what's very interesting there, we found out that when we introduced biometrics, not only was compliance higher, but there was quite the level of privacy increased. So let me break that down. We were doing a study on biometrics with HIV positive mothers. So because of biometrics, they say, I don't need a card that says I am HIV positive. I just come and I use my fingerprint. And therefore I feel that my privacy is more protected. And because of that, compliance was higher. So follow-up for ARTs was higher because of enhanced privacy. The other thing I really want to put out is use, because of the sensitive nature of biometrics, stuff like GDPR, which is a European standard, which is a gold standard when it comes to privacy, increased data protection and impact analysis, and this is really core when it comes to biometrics. The other thing is cost effectiveness. Again, we've seen in Bangladesh, for example, that it resulted to about 35% reduction in fraudulent claims when it comes to insurance claims. We've seen up to 54% across programs in Afghanistan, across programs in forgot the country, Afghanistan, Indonesia. We've seen a massive reduction of fraud because now biometrics is very unique. So when it comes to pay universal healthcare, people now it's easier to achieve that goal because we know who is who, and we're not wastage of resources is really low. We cannot talk about the benefits of biometrics without talking about the concerns and the risks. So if you look at the screen here, I want to point out, you see, this is really my fingerprint. This is a fingerprint we took out in the field. This is a worn out fingerprint. These are scarred fingerprint, and these are burnt fingerprint. So basically, most biometrics have, if it's not designed for worn out fingerprints, for scarred fingerprints, for burnt fingerprints, for calloused fingerprints and calloused hands, then exclusion is imminent. And therefore, someone cannot therefore get the services they require because they've been excluded because of their worn out fingerprint. Secondly, one of the things that has really come out now, it's very clear, is when it comes to facial recognition. It's shown if you're not a white male, it's most likely, most of the facial recognition systems is biased and will misidentify you if you're not a white male. So it's quite important when it comes to biometrics to keep these things in mind, to make sure we use biometrics from a rights perspective and from an inclusion lens. The other key thing here also when it comes to buyers, if you design the system and you're not cognizant of the fact that these things are possible and can happen, people will miss critical services and therefore basically beat what we set out to achieve. Open up for questions, comments. Vinaka. Samira, over to you to take any questions and any comments.
Thank you, Lee. That was a great presentation and it was quite enlightening, and especially in terms of how important it is to have an equity perspective and inclusion perspective. So do we have any questions for Dr. Kironget?
Hi, Samira. I just had one. It's Davina from PG. I just wanted to know, in the implementation of biometrics in sort of the chronic disease profiles, has there been any issues around, for example, identifying mortality records or getting access to people's mortality records when you use biometrics?
Can I answer that? So you remember when I first started and said the biometrics is not legal identity? biometrics can help legal ID. And legal ID is a human right from the time you're born and retired to the time you die. So yes, biometrics has been used to be able to accurately identify people at death. And so does that really answer you? There's not been an issue yet, but it's actually been used to improve identity of people, both at not at birth, but at death also. And maybe just a quick pointer, and I think Katri, I said we should talk about this. A quick pointer is biometrics is very, when it comes to births and the idea of legal identity, biometrics for children is still something that is children under 5 is still something that is heavily being researched now. There is not yet a highly accurate, reliable way of biometrically identifying children under 5. I think NEC Japan and Simprints and Gavi together are doing investing a lot on the research on finding biometrics for children. So I hope I answered your question.
Thanks. I guess I'll just give you a scenario. Let's say I use biometrics for my clinical cases for chronic diseases, for example, my special outpatient clinics. And one of my patients who we use biometrics for passed away. How will we be able to access those records? I guess I'm thinking more on the operational levels if we did go into this.
So what do you mean, how will you be able to access those records? How are you going to identify that in specific individual or?
Specific individuals. Let's say I put in an EMR and I'm able to identify these patient records from their biometrics. Is there a secondary way to also identify them?
Yes. So the beautiful thing about biometrics is, and I know the morbidity of this is strange. Beautiful thing about biometrics, when you choose the biometrics you're using, whether it's facial, which is a picture or fingerprint, as long as it's not the live, what's called live vein print, where it requires a live body to be identified, your biometrics will remain the same even at death. So I've not yet in my whole, and this happened a lot during the Ebola crisis in West Africa. And this was a key way of identifying who died so we can inform their families. So I've not yet seen a problem. As long as you choose the right biometrics, if it's not the live biometrics, like live vein print or live palm print, that requires subdermal measurement, biometrics has proved to be the most viable and the most accurate way to identify people even at death.
Thank you so much. That answers my question. Thank you very much.
Thank you.
Thanks, Dr. Devina. I think Sonia has a question.
Yes, thank you, Samira, for facilitating. Lee, thank you for your presentation. I think for any national government to consider biometrics, a key consideration is costing, and it would be something that they would need to understand, not only upfront costs but ongoing. So, if you, based on your knowledge of the Pacific, so you take a country with a population of 10,000. What sort of costs would that entail to provide the full package, of services? Thank you.
I'm so glad you asked me that, because I think just last week, I'm now going to mention one of the countries that really wrote me like, okay, Lee, tell us what are we looking at? And we went through an exercise with them, and I like going through these exercises with the countries that I deal with. And it was a country of about, again, it's about 10,000 people. And we went through it, and I say the main costs when it comes to biometrics is that, as you mentioned it rightfully, is the CapEx and the OpEx, the capital expenditure and the ongoing operational expenditure. So if you remember, during the presentation, one of the things I said you have to decide is whether there are laws in country that allow for data to be stored on the cloud or in-house. So if the country allows for biometric data to be stored on the cloud, what we did, and the cost was about 200,000 for about 10,000 people. That is initial. And what the ongoing cost, because it's biometrics as a service, you're not storing all that data in your own. You're not employing someone to manage a data center. So we generally the initial cost is about 200,000, and the ongoing cost is just based on the number of new people that you're registering. If you decide to not go the cloud route and have a data center in country, then the cost increases significantly, because therefore you have to make sure there is proper access to the internet to that data center. You have to make sure there's power. You have to make sure there's personnel. You have to train them. You need a hot site, a hot backup site. So in case that goes down, the other site comes on immediately. So you're literally looking at almost 4 times the cost of biometrics as a service.
Even cloud hosting, though, you'd be paying some sort of hosting fee on an annual basis for the data storage.
That's what? Sorry.
You'd pay a hosting fee for data storage.
Yes, that is why it's called biometrics as a service. So you don't really. Yeah, it's included. The hosting fee is included in biometrics as a service. It
would be an annual cost.
Yes, it would be an annual cost, and also most companies would be annually and tier based. So instead of just saying this is a hosting fee, they'll say, oh, if we are registering between 1 million and 10,000, this is the annual fee you pay. So it will be tier based.
But you still would need the upfront cost for training in the cloud-based option, irrespective. So that is a cost that's also going to be upfront, yes. And I assume there will be some residual cost on an annual basis for that purpose and others. Over.
Thank you very much. That is very true. So there's the initial cost, and I have maybe what I'll do at the end of this, I'll share with everyone what a template I use to calculate the different costs. Of course, there's the initial training. Don't forget the gadgets, whether it's fingerprint or facial. There's the gadgets that we're going to use to collect this data, and they will get lost. They will need to be replaced. They'll break down. They'll need to be replaced. Shipping them into the country, I know this has been a major headache. Getting fingerprint equipment into different countries can be a big customs challenge. But to point out, because of COVID, a lot of advancements has been made in contactless biometrics. Therefore, now we are deploying biometrics just using a Samsung phone. So the costs have gone down significantly. The cost of acquiring gadgets, because just a normal Samsung phone, but also the cost of training, because people already know how to use a Samsung phone. So costs have really gone down right now. But what I can do is I'll share with everyone a template that I use to calculate the cost of deploying biometrics. Over.
Thank you, Dr. Lee. That'll be appreciated. I'll circulate that along with the slides. And so, Sonia, does that answer your questions?
Thank you, Samir. Yes, I think Laura's got his hand up over here.
Yeah, Laura's been waiting for a while.
Yeah, no problem. Lee, this is really very helpful. And, thank you for sharing your knowledge and wisdom around this discipline. Just like I mean, as you know, with COVID, now you're seeing a lot of vendors offering COVID solutions, even though this is not really their space. And now you're starting to see biometric solutions that, being offered by vendors that are not necessarily in this space. Can you characterize what makes a good vendor versus a not so good vendor in this space, just to raise our level of awareness?
Yes. I hope I can go back to, there you go. First, it's really good question. The technology must be designed for harsh environments. That's the key. Most vendors now, they're optimized for airports, for nice, cushy, air-conditioned offices. So characteristic of a good vendor, the technology must be designed for last mile solutions, remote, harsh working conditions, and low resource settings. So they should have an offline mode and an online mode. Most technology now is being optimized for the UK, for the US, where the internet, and Europe, where everyone has internet. So that's the first thing. And I don't know why I cannot overemphasize this. Pre-integrations with already leading platforms. DHIS2 is quite common in the region. So look at vendors that already have integrated with DHIS2. So because the integration can really take long, can take up to 6 months. So ensuring that integration is already there. Again, open standards. If you don't ensure the vendor uses ISO standards, otherwise it's called the vendor lock-in. They lock you in. Once they have your data, then you need them forever because they're not using open standards, and that means you cannot run away or move away from them. And finally, privacy by design. Ensure that the vendor you're taking, you're engaging, privacy is at the core of the design of their solution. That's it.
So Lee, I mean, if we basically focus on these 4 evaluation criteria, we should be relatively safe, I guess, in terms of.
Yes, I'm saying,
okay.
yeah, definitely. This is the right way with this 4 criterias, without going into details of each of them, but this is the perfect way to say, now this is a vendor we can work with.
Okay, good. Thank you very much, Lee.
Thank you, Lauro. Katri, did you have a question?
Yeah, I actually have. I was just wondering that there have been some of the pilots in the Pacific, they're using the biometrics, but it's not really adopted, at the scale. And based on your review, what you have seen so far, what you would think that, would be the best impact scenario for the Pacific, to start using the biometrics? The public health screening that they have done, in some of the countries. There's also the NCD management, through the EMR that they have done in Kiribati. And what I've seen as well, that this been used, for deduplicate, and keep, the patient registry up to date. But I would kind of just want to know, what would be the easiest, the way that the countries could benefit, the biometrics with the low cost, like a lowest cost and biggest impact kind of scenario.
So in my experience, when I work with the Ministry of Health in a specific country, when I'm trying to explain the benefits of biometrics, I would defer to this point. And one of the things I realized is, how do you scale it? So the Pacific Island countries are quite lucky in the sense that, and unlucky at the same time, in the sense they're small and yet very remote, but also because of the geographical nature, it makes it also difficult to deploy biometrics. So what I figured out, the best way to scale it is, first of all, highlighting the benefits. but also making sure. So let me try and rephrase that differently by giving an example. So when I work with triad nurses, one of the things I do is I sit with them and see, when we introduce biometrics, I really sit with them and say, do you see biometrics as improving your job, or is giving you an extra bureaucracy and extra? And most of the time they're like, yeah, I'm a nurse, I don't want to do all this. And so when you sit with them and you demonstrate the benefits and they accept the benefits, you sit with them and they help you design the system in such a way it's really bringing in, they see, it used to take them 10 minutes, now it takes them 5 minutes. That is the only way to ensure you scale biometrics, but by making sure the core guys with the frontline health workers really understand the benefit of it and they see the benefit of it. Katri, am I answering your question? I'm all over the place.
No, that's yeah. Thank you for that reflection. Thank you.
Lee, I think what Katri was asking is really what would be a good entry point to start introducing biometrics. Yeah.
So again, for me, the only way to do it is work with the frontline health workers and ensure that you design the system that they actually see the benefits. If frontline health workers don't see it, that will completely tank. So if you don't, because they're really the guys who are collecting their biometrics. So if they don't see the benefit, so you design with them, sit with them, get 10 of them into a room. Say, let's go through the process of how do you do your triage? How do you register a patient? How do you ensure that this is the patient and they're coming for treatment? Then see and prove that biometrics is actually making their work easier. If you don't demonstrate it to them that biometrics is actually cutting the bureaucracy and bringing in efficiency, they will completely just say yes, yes, yes. But when it comes to rolling out, they will not use it and it's going to be a failure. So core is to design with the frontline health workers to ensure that they see the benefit.
Thanks, Lee.
I did think maybe what Katri was trying to ask was, is there a particular use case? You know, like, should we be looking at a particular program that where you would think it would be most valuable?
Yes, there are quite a few cases. I'm happy to share. Ada is one of them from India, where you see it's already saving 11 billion a year. And there are numerous cases. Kiribati is doing something quite similar with the University of Sydney and Simprint, and they've measured out the benefits. As also we've pointed out, there's quite, as you can see, there are many use cases. It just depends on really what you really want to look at. Vaccines, for example, you've seen that in Nigeria, in one of the country, Chad, in Rwanda, we've seen WHO data and Gavi data not corresponding to MIS data from the Ministry of Health. So there's quite a lot of use cases that we can point out to. Is there any specific thing that you're concerned with that I can actually highlight?
Well, I guess, you know, like this is Katri, one of my question was that a lot of hospitals, they have issues to maintain their patient registry. And I was just wondering that, you know, the feasibility, you know, they introduced this, you know, in the hospital when you know, the countries don't have the unique health identifiers and they might have EMR numbers, but the people don't carry them around and there's a lot of name convention issues. So if that would be, you know, something that, you know, the countries can consider, or, and the other, you know, the good example that I have seen is for this surveillance and public health surveillance, for instance, collected TB cases, in the islands. So there are, the few things that, like seems to be that they've been successful in the Pacific context.
Yes, I think also, I think Katri, it's nice you mentioned that. And I think the Pacific they're coming in late to the game, but it's interesting that they're finally catching up because, and this is quite interesting. What I've been talking also I've been talking to different countries in the Pacific, and one of the things that's always been a recurring theme is, let's get a unique identifier for health, but how do we link that to a foundational identity? So the questions I've been getting a lot is, okay, we understand now, we can use it, we can get a unique ID in the health space, but how do we link that out to a national ID? Or how do we link that out to voter registration or something? So it's always been, I've found out in the Pacific, they're saying, okay, we understand now this is working, but how do we now use this as a basis for a greater unique identifier for our citizens, not only in health, but across different sectors?
I see that Dr. Tang has a question.
Yes, Professor Tang has been waiting for a while. Tang, would you like to unmute and ask your question?
Yeah, thanks, Lee, for the talk. I posed my question on the chat, but I guess the question, one of the other things to follow on from the discussion you just had about the use cases with on the question that Katri raised, and linking, I guess the big question is linking it to a national ID system. But I guess the other thing I'm interested in is actually what are the extra costs involved in linking to the EHR and various other kind of health systems, health information systems with that system. But I guess my main question is, there will be, I guess most countries will have a regulation before they actually to cover the implementation of a ID system. But what about the regulations in terms of if it is cloud storage? Do we have to consider, or does the country have to consider the storage, and what are the rules and regulations across countries and so on? And has there been any, actual cases of either good things happening or bad things happening?
Yeah, a lot of bad things have happened. I can actually confirm. So I'm going to use Ethiopia again as an example, which is quite unfortunate because there's a war going on now. Ethiopia in 2019 asked to 18 asked to deploy, 19 asked to deploy biometrics. But the Minister of Health went ahead to deploy biometrics, but they didn't consider that the country does not have a policy on cloud storage. So they went ahead and engaged a technology firm, a biometrics firm, to deploy biometrics, which uses the cloud storage. And what they midway through the project, I think the Deputy Minister of Health decides, and they use this, I'm going to quote what was said. They say, we don't want a Zimbabwe situation. And the Zimbabwe situation was, say, oh, what if we store stuff on the cloud and then we get sanctioned by the US and therefore we can't have access to our data that's stored in the cloud? So that initiates a very uncomfortable conversation. And that's why I put it out here. Make sure, first of all, make sure you have, where was it here? Before you deploy biometrics, where was it? Before you deploy biometrics, make sure you consider the fact that each country here, sorry. So this, is there a legal basis for collecting that? Otherwise, you really fail. I have many examples, Kenya being one of them, one of the more technologically advanced countries. that's willing to deploy biometrics, but the Supreme Court shut them down because they didn't have the legal basis of storing people's data in the cloud. Over.
Or for that matter, storing it on a local network.
So if you store it on, this is what at the end of this, I'll demonstrate, at the end of this study, I'll demonstrate the two options. Storing it in a local network also comes with a lot more costs. It's probably 4 times more expensive to have it locally than on the cloud. And that's why when I talk to the countries in the Pacific, I like to point out New Zealand is one of the more advanced when it comes to biometrics and patient data. And they have a very clear way of storing, advising different government bodies on how to store data in the cloud. They actually have a full department dealing with that.
Just a follow-up question, Ali, that Supreme Court decision, was that based on domestic constitutional rights of the citizens, or was it based on some lack of international protection if for cross-border, if cloud computing involves
it was actually based on the local constitution.
Okay, thanks.
And I really like this example. I don't know if you can see my notes where I've put example of Huduma number in Kenya, which was heralded as a game changer by everyone in the world. And then a month ago, the Supreme Court says, sorry, this is illegal. We cannot go ahead with it. So it's based on the local constitution. And it's someone who was trying to cut corners, but not ensuring that, again, there is a legal basis to collect. Actually, what I forgot here, collect, sharing, and storing biometric data. Over.
I think Dr. Eric has a question here, and then I'm going to ask mine.
Yeah. So Dr. Eric Rafai from the Fiji Ministry of Health, he's asking if there is any public health activity in a Pacific Island country that can be easily piloted for a biometric solution, noting the examples that you have presented already, and how can support be gained to pilot this technology?
All right, so there is a lot going on in the, okay, so I have to say this, it's still, in the Pacific countries, biometrics is still in the nascent stage, but there's a lot going on. Kiribati, and there's a few other countries that I'm talking to, Marshall Islands, Tuvalu, who are really keen on pushing this forward, and I've started working with them individually. So without going into the specific, like for example, in Tuvalu, we are talking about ensuring, first of all, that there is a legal basis to do this, and the costing, the CapEx and the OpEx. In Kiribati, they're doing something small, as Katri has pointed out, with NTDs there, but also they're starting something with SIM prints on tuberculosis. So there's quite a few cases of what's going on there, but specifically what we've been trying to do now, Katri and I, is trying to demonstrate how we can help individual countries, because they're very unique. As I said, for example, Tuvalu is very interested. They were like, okay, we want to do this. What's the cost? How can we do it? So Kiribati is completely different. So there's a lot of cases going on, but we are giving them support on an individual basis based on their needs and where they are. And I guess and Katri, not to speak out of turn, but I guess what we're trying to do is to establish a mechanism, a sort of, if you want to do it, we will give you the support that you need based on where you are. We'll analyze exactly what you want in that specific context and give you the support that you really want. So it's not a cookie cutter approach, but more customized by country and by needs.
Thank you, Dr. Lee. Dr. Wendy Snowden, who's the WHO country officer for Kiribati, she's just highlighted that the Kiribati NCD work is no longer happening because it was supported by an outside partner who is no longer present. But as Dr. Lee mentioned, there are other examples and other countries who are carrying on the work. So maybe Fiji can take lessons from it. Dr. Eric, does that answer your question?
Yes, thank you. I guess much of the digital regulatory is from one government institution. So I was more thinking of, piloting something that we can justify its use by showing it to this major government institution that, we can successfully using it in country. Small pilot for an activity such as I don't know, a screening project or a research project or something like that, that we can use the results to justify its use in application in a bigger scale.
Yeah.
So that's where I'm coming from.
All right.
Yeah.
So normally, what I would say is let's use equivalent economies, equivalent countries, instead of redefining the wheel. So we look at what's happened, let's say in Fiji, or let's see what's happened, equivalent economies, and it doesn't have to be the Pacific to be very specific. We can have equivalent countries across the globe and say, look, this is already happening. And what we'll normally do is we can do a very quick, cost-effective center of excellence when it comes to biometrics. I'll give you a very good example. In Bangladesh, before we rolled it out national, what we did is we worked with a small slum area in Dhaka, the capital city. And we're quickly able to demonstrate to the Ministry of ICT and the Ministry of Health that, you see, we're able now to get these benefits. But beyond that, when you deploy a biometrics project, you start with the pilots because you don't want to invest a lot of money on something that does not work. So you start with a small pilot and then demonstrate the benefits before you scale it. So again, I'm now with the different countries I'm already working with in the Pacific, is designing these pilots for each of these different countries and tell them, okay, let's start with this. See first, let's document the benefits. Let's document the challenges. Let's compare it with the challenges in other countries. Now, let's see if we want to scale it or not. But the key thing is we're not reinventing the wheel. A lot of people have done this before. So we compare it to similar environments, and we do a small pilot and ensure that we're collecting all this data and evidence and showing the ministries or whoever needs to see the data and see, these are the benefits and this is how we're going to scale it. And these are the costs. And does that make sense to you?
Thank you. That does make sense. Thank you.
Thank you, Dr. Eric. Laura, did you want to go ahead?
Yeah, thanks a lot. And Lee, again, I'm just trying to suck as much as information from this webinar because it's really useful. So, it's very timely because it just so happens that I'm actually helping the Asian Development Bank design a technical assistance project for Cambodia in piloting the adoption of a universal health identifier and biometrics. And so, when you're trying to design a TA, you have to put the financial analysis. And the question I have is, what kind of a payback are you looking at, or can you expect if you introduce biometrics? I understand that countries are different, but on average, what would be the average benchmark?
So that is quite cool. It's cool in two things. First of all, Cambodia, since 2005, I've not missed going back to Cambodia every single year. I've gone back to Cambodia since 2005, every single year. So I love that country a lot. Second, we've just finished a study, and I'm not sure if maybe we can share the results. It's actually $6 to $1 spent. So the ROI is $6 to $1 spent.
$6 in savings, or sorry, I don't understand the rate.
In savings.
Okay, right.
Yeah. So for every dollar you spend on biometrics, you save $6 down the line on recurring costs and logistic costs and all that.
And in what period?
Oh my God, I have to look at the study. I think it was, I'm not sure, maybe a year. I'm sorry, I cannot really say exactly how long.
Yeah,
I'll have to look, check the data again. But I know for sure what we did, and this was with MIT labs, was about $6 to every dollar spent.
Right. With a ratio like that, I mean, I would assume that the payback would be quite immediate.
It would maybe a year.
Yeah.
Not really
Not
a year.
Yeah. Not decades, right?
Yeah, no, definitely not decades. I'll again, let me look at the study, but yeah, it's a year, I think.
Right, okay.
Yeah. It's not decades. It's all, so let me explain. So a bit of biometrics really has almost immediate benefits. So from voter registration to CRVS to mini vaccine campaigns, EPI campaigns, biometrics generally has almost immediate benefits from just knowing who is who.
Mm-hmm.
And I would love to know more about what you're doing in Cambodia later on.
Sure, we can certainly take that offline.
Yeah.
All right. Thanks again, Lee. This is very, very helpful.
Cheers. I thought I had someone else had a question.
No, that was Michael thanking you, and he had to leave. So does anybody else have any questions or comments?
No, just if Lee can share the report, that'd be good.
All right. So I'll share. So what I'll do after this, I'll share first of all the framework on calculating the cost of biometrics, and later on, me and Katri will do a major report, which we'll share maybe next week on the work we've done. It'll be more detailed. It's what fed into this presentation. So we'll share a major report on this later on, maybe next week.
Oh no, I meant the Cambodian report. That'd be really useful.
Oh yeah, sure.
Okay, so if there's no other questions or comments, maybe we can wrap up.
10 minutes ahead of time, good.
Yeah, it was a great discussion, and thank you everyone for participating so enthusiastically. So next Tuesday, we have another webinar on smart vaccine certificates for cross-border travel, which will be presented by Sunia and Laura. So you will receive an invitation for that shortly. So thank you very much, Dr. Lee, for this wonderful presentation. And it's such an important topic, and this conversation needs to be carried on and further across. So everyone, thank you very much. Have a good evening, good day. depending on where you're from.
Thank you. Thank you, everyone.
Thank you